Hello, my name is Nicole Riddle. I am going to speak today about accommodations for disabilities, valuing all people in pathology equally. Today, some of the objectives we will cover is to define disability and disability inclusion, give a little bit of an overview of some disability statistics, summarize some guidelines for interacting with people with disabilities, and then, of course, talk about disabilities in medicine and pathology specifically. Why me? Why am I giving this lecture? So my name, and like I said, is Nicole Riddle. I'm a practicing pathologist in Tampa, Florida at Tampa General Hospital, the academic hospital for the University of South Florida. These are some pictures of me that both happen to be from the AMA meeting where I've been an active delegate for 20 years now. The picture on the left is the scooter that I drive around in, and me in my more professional garb. And then the one on the right is just kind of fun. It highlights the scooter, but the AMA sometimes do what they do is the tiny clinic at their meeting. So that's me and my scooter in the tiny clinic that they had at a meeting. But that just kind of shows how I often get around. I have McCune-Albright fibrous dysplasia. I love that pathologists are one of the few specialties that actually know what that means. So I have been on crutches since I was 8, and I often use a wheelchair or a scooter either to get around more easily or when I break things because the wheelchair is the only way I can get around. And so that is why I will be speaking today more from the physical disability side of things. Real quick definition of disability. According to the ADA, a person with a disability is a person who has a physical or mental impairment that substantially limits one or more major life activities. And I wanted to take this moment to talk about how, during this session, I'm going to talk kind of in generalities for ease of use. Of course, every individual is different. Every individual situation is different. There's a lot of nuance. It's also going to be a rather US-centric lecture because trying to cover the laws and rules of every culture across the world would have been extremely time-consuming. Also, I plan on hopefully using all of the proper terms, but terms matter to different people. Certain people where terms are very much considered generally in the norm, some people still don't like that. For example, there are terms that people could use about wheelchair users that some people might get very offended by. I personally don't mind, and I might use them, or vice versa. That is not a carte blanche, don't be mad at me for what I say sort of situation. That's not what I mean. I just know that if I do say something that somebody finds offensive, I absolutely do not mean to. And please feel free to reach out and comment to me somehow and let me know a better way where I could address it or restructure a sentence or whatever in the future. I liked this definition. You can find many definitions of disabilities. An umbrella term for impairments, activity limitations, participation restrictions, referring to the negative aspects of the interactions between an individual with a health condition and that individual's contextual factors. That seemed a very cognitive way to kind of think about disability, but it seemed very all-encompassing, and I kind of enjoyed that definition, so I added that there. Also, a person with a disability, different definition, a person suffering from not less than 40% of any disability as certified by a medical authority. And that is the definition that is in, like, if you try to get Social Security disability or something like that, that is the definition that they use. Also, in this paper about educating healthcare professionals, they use the definition as a universal experience that affects nearly everyone without exception at some time in their lives. So the beginning part of this lecture is kind of going to talk a little bit about disability as a whole that all society has, and that as physicians, we definitely need to think of and address because we take care of patients. And then, of course, it's a different kind of standpoint of coming from how it affects those of us in healthcare that have disabilities and how to navigate systems. The WHO has these distinctions that they talk about, and I say they're slightly outdated. They were originally written in like the 60s, but they still, as of 2012, have kept them up. But an impairment is any loss or abnormality of psychological, physiological, or anatomical structure of function. So that's an impairment. A disability is then a restriction or lack of ability resulting from that impairment. So inability to perform either a certain activity in the manner or within a range considered normal for a human being. And that is the terminology that they use, but that's kind of what disability is. And then handicap, a handicap is a disadvantage for a given individual resulting from impairment or disability which prevents fulfillment of a role that is considered normal, and that of course could depend on age, sex, social, cultural factors, et cetera, for that individual. So impairments can give you disabilities, and then if you have a disability, that might lead to you having a handicap. These are some statistics from the CDC, and again, most of my statistics come from the CDC or NIH, or like the ones about visual impairments come specifically from the National Eye Institute, et cetera. If you Google, you might find slightly different statistics. They're all roughly close, but if you find 13.6 and I said 13.8, please note that there are some variations out there. But according to the CDC in 2022, 61 million adults in the US have a disability. And that is, all adults of all ages. And that makes sense because clearly older individuals tend to be more likely to have disabilities. 26% of adults have some sort of disability. So 61 million as a whole, 26%, which is a quarter, 1 in 4. Disability is highest by survey and CDC statistics in the South. Again, over age 65, that's when it's 2 in 5. Women are more likely than men to have a disability. And then American Indians and Alaskan Natives also have a higher percentage of disability. Here's just some prevalence by disability type, and these are some of the statistics that I was talking about. The numbers could be slightly different depending on where you look, but again, this is from the CDC website. And these are the percentage of people in the US that have each of either mobility issues, cognition issues, independent living issues, hearing, et cetera. Cognition issues, we'll talk about this here. So there's intellectual disabilities and there's cognitive disabilities, and they were sometimes used interchangeably. Nowadays, it's generally considered that cognitive disability has something to do with like an obstacle to learning. So you have difficulty focusing for a certain amount of time, or you might transpose words. That's usually where like ADHD would fall in, or dyslexia, stuff like that. Intellectual disability is something that affects your IQ. Maybe it can also affect your socializing with others, understanding information, all those things, but those are the more disabilities such as Down syndromes or capabilities where where one's IQ might be lower, and so it's kind of harder for them to maybe wrap their minds around certain ideas and knowledge. So though, as I'm sure you guys are aware, we certainly have people in medicine and pathology that might have cognitive disabilities, ADHD, dyslexia. Typically, people with intellectual disabilities or things that truly affect your IQ in significant ways don't usually make it into medicine. But we definitely take care of them as patients, so it's important to note. These are more of the numbers, and again, so visual impairment. So about 4% or 12 million people in the US over the age of 40 have some sort of visual impairment. Right now, they say there's 1.3 million people that that would qualify as being blind, which is greater than a 2400 eye vision. 4.2 million are uncorrectable, so can't get it back to 2020. And they say that is going to double by 2050. That's from the National Eye Institute, that it'll be up to 9 million people that have uncorrectable vision problems and over 2 million people that are legally blind. And then the numbers there showing you what children have visual impairment, 3% are blind. For hearing difficulties, 15%, 48 million of adults report hearing loss, not necessarily to the point where they have a hearing disability. Of course, lots of times hearing is what goes when you are older, especially if you like to go to either clubs or concerts or loud shows when you were younger, or people that were musicians. And it depends. I put 2 to 50% say it's disabling because I could find a very large subset of variations in statistics. But clearly, as people get older, whether they need to start using hearing aids or stuff like that, that's usually at some point then affecting their life, would be considered a disability. Like I said, cognitive, intellectual are often put together, so it's kind of hard to parse the statistics out. Physical disability is, as a whole, often considered the most common disability. If you think about not being able to correct it. A lot of times hearing problems or whatever can easily be corrected. With physical disabilities, those are harder to correct. So if you read certain papers, they'll say that a physical disability is the most common in the US. That's, of course, if you don't include psychiatric. Again, whether or not you consider psychiatric a disability, at what point does it become a disability? That's a whole lecture in and of itself, but it is important to talk about both as we are physicians taking care of patients, and people in medicine are certainly still capable of having anxiety or depression or psychiatric disorders. Again, usually not to the extreme that it affects their work, even though I'm sure we all know a few people that maybe take the OCD tendencies we all tend to have, to a point that does make it difficult for them to work, and they need to address that in order to function. So again, there's different characteristics in disability. They can be mild, moderate, severe, different types like we were talking about. And then I like to focus on the visibility here just a moment, because some are just not visible at all. If you have ADHD or dyslexia, somebody's not going to look at you and be like, oh, that person sometimes transposes their letters. Some could be visibly too informed, like if they know you have, you're on the spectrum, the autism spectrum, maybe they're like, oh yeah, I could see that now when he's doing certain movements or she's acting a certain way, that maybe that's a comforting thing. But other people might not necessarily notice. And then of course there's visible to everyone always, which is, clearly me wheeling around in my scooter. People are going to notice that. Some challenges and disadvantages. It can be difficult for people in general who have disabilities to obtain health care or preventative screenings. They have a higher incidence of health disparities than those without disabilities. They have an increased risk of secondary conditions. And then in general, they report a higher rate of negative experience with healthcare providers. And that's one of the things at the bottom there that I very much feel like as physicians, we should think of and try to address, that not only do we as a whole society maybe need to think about being more inclusive, but we need to make sure that our healthcare workers know how to interact with people of all different experiences, so that we don't ever have somebody feel like they can't go see a physician because they're not comfortable talking to them about whatever their disability is. These are just some numbers to show that, whether it's routine follow-up, whether it's the dentist, going to get flu vaccines, breast exams, they have people with disabilities, which is in the pink, have a lower rate of doing all of those things than people without. Oh, and I lost my arrow again. There it goes. And then general health conditions. So just in general, they also tend to have, rate as having fair or poor health overall. They have, people with disabilities have a higher rate of heart disease, diabetes, hypertension, high cholesterol, etc. There's just more of those chronic health conditions, clearly much more arthritis, but they even have increased risk of cancer, COPD, clearly depression, that one makes sense. Obesity, smoking, all of these things are more common in people that have other disabilities as well. Also, disability intersection. It's always important to talk about the intersection of things that could possibly affect somebody's life and experience. People that are more likely to have a disability are people of color, people of lower socioeconomic class, and then people with marginalized gender identities, transgender individuals, LGBTQ, et cetera. And then people with disabilities are actually also more likely to face sexual violence. There's economic reasons behind that. And then also just, maybe they have a harder time getting away or speaking up, or might, be in a situation that they cannot easily get out of. So historically, disability represented in the media usually had, two different type of people. They were either the villains, and I did take this from somebody else's example. I thought they were fun, Captain Hook, or the gentleman there who was from Pirates of the Caribbean. But, they often show, people with disabilities as being the bad guys and or the victim. You have Tiny Tim, I was going to say, I can't remember his name at the moment, the Hunchback of Notre Dame, which would not be the appropriate way to refer to him. And so it's one or the other. We either fear them or pity them, kind of historically. Now, there are a few newer models of disability, more than the historical. There's the medical model, which is what most of us have been brought up to think, and what has kind of been the norm for years. And that is that disability is a result of a person's physical impairments, and we seek to cure it. Like if they have a problem, we can fix it, and that's the problem. Like that's the solution, is fixing that person's problem, then everything will be okay. The new social model is that disability is just a result of the way society is organized, rather than by a person's impairment, and seeks to remove those barriers. And there's kind of this thing here that kind of exemplifies that, where, the medical model is like, oh, well, the impairment is the problem. If we can get it so that she can walk, well, then there won't be a problem anymore. Where the social model is, well, clearly the stairs are the problem. If we could get rid of the stairs, if we put in a ramp, if we had an elevator, then she'd be able to get around. So nowadays, kind of social model is a better way of thinking about it, where somebody doesn't have an impairment inherently if the system is set up in such a way that they don't have a problem. So they might have an impairment, but if it doesn't affect how they live their life, then they may or may not, quote, have a disability, and they certainly might not have a handicap, kind of based on those definitions at the beginning. Nowadays, people are moving more to the human rights model of disability, which for me, I kind of think of takes the social model even farther, which basically says, disability is a natural part of human diversity. Like, there's plenty of people that do have different disabilities. Any of us could become disabled at any point in time, accident, have a stroke, fall and hit your head, get hit by a car, sprain your ankle, and, skiing and break your femur. Clearly we could all sometimes have these things happen to us. And then they say that people with disability, they have the same rights as everyone else, which I feel most people would probably agree with, or at least nowadays it would not be considered appropriate to come out and say, oh yes, no, people with disability do not have the same rights as everyone else, like they used to do once upon a time. So basically, since they have the rights of everyone else, we can't use that disability in order to deny them access to something. So that basically calls for full inclusion of people, because it's just a human right. It is the human right to be able to use public transportation that everybody else can use. It's the human right to be able to get into a convention center or a concert hall that everyone else can use. And I like it. It's like, I'm not disabled, I'm not differently abled, or especially abled, or exceptionally abled. I'm just an accountant in a wheelchair. And I kind of think about that. Like, I will call myself disabled, and it does fit in society nowadays. But at the same time, I'm also just a pathologist who likes to sit a lot and won't necessarily stand for a really long time. So when you talk about disability and inclusion, I found this chart from this lecture down here, and I liked it. And it kind of talks about how, exclusion is clearly people giving people out. We had segregation in many different ways, where, separate is inherently not equal. So, you know, giving something to a different group of people inherently makes it not equal or not the same. You can integrate them. I think about this, you know, maybe necessarily, I think about this lots of times when I go to an event, and it's an event that has multiple levels on, like, you know, a step down, step down, step down. And it's like, I can get into this one level, but because there's no ramp, I can't get into the rest. That's like how I vision this down here is, you know, I could be included, I could go, but at the same time, it's not, you know, fully immersive. And then inclusion is, of course, just making it so that the people that have either the physical, whether it's visual, whether it's mobility, whether it's hearing, whatever the issue is, can fully access what everybody else would be able to access. The importance of inclusion, it is just a natural part of being human. We will all at some point get slower than we are now, or have hearing problems or vision problems, etc. The disability community is actually the world's largest minority. I know that's kind of a loaded statement to say that, but up until a decade or so ago, you know, not only were we the largest minority, but we were the one least likely to be talked about. And then Edward Roberts says, you know, disability is the most equal opportunity minority because anyone could join at any time, and with time, most people will. I didn't necessarily want to belabor all of this. I know there's a lot of words on that slide, but basically in general, you should always use person first language. So a person is not impaired or handicapped or disabled. You know, they are a person with a disability, or are differently abled. There are people that don't want to be called disabled, who are differently abled. So just in general, you're not saying the person is blind or visually impaired. You say they are a person with low vision, or a person who is hard of hearing. This is one that I myself, I have said wheelchair bound before when I've broken my pelvis and I can't get out of it. I'm like, I'm wheelchair bound. Everyone knows what that means. There are people who would not appreciate that. It's not the person first. I would be a person who uses a wheelchair, those sorts of things. And I am a person who always walks with crutches. You won't see me without them because I really can't take a step without them. And then disability assumptions. So I found this thing on the left. This thing on the left was actually tweeted by George Takei, who I do love. And it upset people, and he basically is an equal opportunity tweeter. So he says, you know, there has been a miracle in the alcohol aisle. And this happens all the time. I get this a lot, where people assume that because she's in a wheelchair, she must not be able to stand, like that she must be faking it. And I certainly can appreciate that, not dichotomy, but that people assume that, like, oh, if you're in a wheelchair, then clearly you can't get out of it. But it's like, yes, I use crutches. Yes, sometimes you'll see me in a wheelchair, and you might also see me dancing someday. When you do see one dancing, or when you do see something like that, it might be difficult for them. Know that they might regret it the next day because they will be exceptionally sore. And I always say, if I'm having a good day and I do something fun, I will usually turn the next day or two into a bad day. And that's the choice that we make. And that's also why I included this image on the right. So this is Jazz. She's the one who wrote the song Victoria's Secret, if you guys haven't heard her. And she did a flash mob in front of a Victoria's Secret. And in that flash mob, she included this woman who you can see just over her shoulder, who is in a wheelchair. And in the video, this woman moves her legs. Like, while she's dancing, she's moving her legs. And people lambasted Jazz as saying, you know, that you're having somebody fake using a wheelchair in order for publicity's sake. That is not what they did. That woman is a permanent wheelchair user, and that's one of the assumptions people make, that if you're a wheelchair, you must not be able to move your legs at all. That is not necessarily the case and how that works. And so I just thought it was a good way to kind of bring those up, that people do have assumptions. And oftentimes, you know, it's human nature. They come to us naturally. They come to myself as well. But you shouldn't necessarily jump to conclusions, or you should always wonder, oh, maybe there's, now if I see somebody who claims they have a physical disability, so they're parking in a disabled spot and then they get out and run up the stairs carrying a basket of laundry, I'm like, or run around there, I'm like, okay, maybe that's not actually their handicap sticker. But at the same time, maybe they have it because they have bad Crohn's disease and bad UC, and sometimes they need to be close to a store in order to get to a restroom, and maybe it's not the mobility issue that's their issue. So you just never know exactly what somebody's story is, which is somebody who has been on crutches since I was a teen and driving myself around. I've certainly had plenty of people that have questioned my legitimacy of parking where I park or doing what I do. And so it's a good reminder to always ask before you just assume. Disabilities and employment. Thought I would cover this real quickly. Some kind of general do's and don'ts. You're not allowed to ask somebody specifically about when they're going to have kids or what they can do. You're supposed to just be in general. If you see somebody who's not feeling well, you can ask, how are you? If you have an employee who looks ill and tired, you can ask if they're feeling okay. I thought this was interesting in the time of COVID. If somebody's sneezing or coughing, just ask, oh, you have illness or allergies, because kind of nonchalant. They'll be like, oh, do you have COVID? Or, oh, do you have this? Maybe they'll want to tell you. Maybe they have COPD and they don't want to, mention that. And they do not have to. You shouldn't ask specifically whether they can perform job functions. That one you can kind of get away with by law. Like, they need to be able to do the work, but we'll go over in a minute kind of the good way to ask about that. You can ask right up if you've been drinking or using drugs. Those are illegal. You're not allowed to do them at work, so you are allowed to just basically be like, if you wanted to be that bold, ask somebody about that. Some kind of don'ts, and this is where I was talking about, don't ask about genetic information, don't talk about any prior workers' comp history, you don't ask about prescription drugs that they take. Don't ask some broad question that's likely to elicit information about disability, like, oh, do you have any other impairments that I should know of, sort of thing. And then how you ask and your attitude about it very much could affect how it's perceived. Makes sense. So if you say, well, the job requires X, can you do that? That has kind of a different feel. I mean, it's fair, you need to know if they can, but it has a different feel to then, this job requires X. Will you need anything to perform those duties? So when I was getting hired for my first job, they just straight up asked me, like, I see you're on crutches. Is there anything I need to know that like you would need help doing? And I know they were very much trying to be tactful, and I thought what they asked was fine. But it is important or preferred, to maybe seem like you're willing to have the conversation and, ask in such a way that's more open-ended and willing to offer some help, give the positive message rather than the like, how annoying is this going to be? What problem is this going to be? That sort of thing. Now, as physicians, we are ingrained with ableism. We have always said, like, this is how this test would look like in a normal person like you and me. This is what normal pulmonary function tests look like. This is how a normal person walks and talks and et cetera. How one normally does, whatever it is we're talking about. This also bothers me a lot when we're talking about HPV or HIV, STDs in general. We kind of always talk about them as if a physician has never had them, as if nobody in the room when we're talking about them has ever possibly had them or has them. And I always try to keep that in mind when I'm talking about them. And then that's just partially how we're ingrained to think that, and part of it is because the technical standards that medical schools always had as requirements to get in included that. You had to be able to draw blood. You had to be able to do surgery. You had to be able to do CPR. You had to physically be able to do all these things in order to get into medical schools, which in a minute we'll talk about, they use that for years and some still do to not let people into medical school. In medical school, they're currently, I think it's up to, some places I found like 3.1%, but roughly 3% of graduating medical students will have some form of disability that they will claim. That, these are on surveys by the AAMC. but it's less than 5% that are physical or sensory. So that largely includes ADHD, depression, anxiety, dyslexia, those sorts of things. They are often the sort of disability, and I don't call them out as being less than. That's not why I'm calling them out. I'm calling them out because they're usually something that the person themselves can physically accommodate or figure out how to accommodate without needing the school's help. Like depending on somebody's cognitive issue or ADHD, maybe they need, slightly different test times or work hours. But in general, coming to terms with how you're going to study if you have ADHD or how you're going to interact with people if you are on the autism spectrum is very much a personal thing. Where physically, or like a sensory thing, if you need help seeing the test and doing the anatomy work because you need, special time to be able to really get up close because your eyesight is bad, or, if you need an accommodation where, you can't run up the stairs like everybody else, that is something that then involves the school. And so it usually is a slightly different dimension of accessibility to help with that. And then in general, in med school, most med schools have like no education about disabilities much at all. We just kind of assume that since we take care of patients, we must understand it. But as I'm sure many of y'all know, that is unfortunately not the case. So UCSF does have a 2-hour session. I personally applaud them for that. A session is better than no session at all. Of course, I don't necessarily think 2 hours is enough, but they do talk about privilege awareness. They have student-led discussions. They have brainstorming for overcoming barriers and biases. Like I said, all in a 2-hour session. If I had my way, I'd probably make it like a week-long curriculum where, a 1-day session based on the above sounds great. And then also including people to come and share their stories to actually hear from patients, or maybe if there happens to be colleagues who would be willing to share in the class or in the med school in another class. And then spend a day in a wheelchair trying to go around and on crutches or with a blindfold or some sort of heavy nudie noise canceling headphones, something so that you can truly appreciate, oh, wait, I can't get in there. Oh, wait, I can't do this. Oh, I can't go to the bathroom. Oh, I can't open that door. It's usually very eye-opening. People that hang out with me say it's very eye-opening. When I've had to text people and be like, hey, can you come let me out of the bathroom? I can't get the door open. Like, it's a thing. If you're my friend, I might have to do that someday. So people with disabilities in medicine, I chose these 4 people. There's thousands of physicians that have disabilities. Only a few of them kind of are really known about. These people have all written articles or had articles written about them. So that is why I chose them. Michael Ain has achondroplasia, and he's an orthopedic surgeon. Sherry Blowett was paralyzed as a toddler in a farming accident. Chris Moreland is profoundly deaf and has been from birth. He's actually a friend of mine. We were faculty together at UT San Antonio and have done sessions together before. And then Maggie Salinger, she did not say, but some autoimmune disorders that, just kind of affected just the hours she needed to keep, not the totals necessarily, but how she broke them down and, just a little bit of accommodating in order to get through. I also found, since you can see that there's Johns Hopkins, a couple Harvard up here, many, at least of the articles that I saw for the physicians that are disabled are in the Northeast. There were quite a few from Harvard, a handful from up in New York. I don't know if it's because that's where people with physical disabilities go to work, or if it's just because those are the people that want to write articles, but I did find quite a few from there. So just in general, hospitals and physical disabilities. Now we'll kind of talk about, some of the things I've had to deal with and some things kind of to keep in mind. The physician parking requires stairs. Where I used to work, the physician parking, you can only get there by going up and down stairs, and they refused to do anything about it. And I'm like, you realize that you're telling me I have to park in visitor parking only because I'm disabled. Like that's the only reason why I can't otherwise have the privilege of parking in the physician lot that theoretically, I deserve because I'm a physician. And then not only that, but in order to get in from the visitor parking, it was like this really long ramp. Like we're talking like 100 yards of this ramp. So when I was trying to push myself in my wheelchair, it was horrible. Bathrooms with really heavy doors. I've talked about how I've been locked in bathrooms before. When doors are exceptionally heavy and you physically can't open them. Yes, I have broken bones in my back trying to open doors before. Or they don't have a handicap stall. Or my personal favorite, again, where I used to work, they put a sign on the door that has the wheelchair symbol, but then the stall itself is still really tiny. And so I just like go in and I just like park my wheelchair just like in the main area and have to leave the door open while I'm going to the bathroom because that's my only option. And I always say, yeah, handicap sign does not in and of itself make a bathroom handicap accessible. Or, you know, said university center in the very large city, put in a brand new gift shop slash cafe in the foyer of their hospital. It was big, it was beautiful. It had 2-story glass doors that did not have buttons on them. And they said had to remain closed. I don't know why, it was like a fire thing, or said they wouldn't keep them open. I'm like, that just makes no sense. Like, you just did a multi-million-dollar renovation. Why would you make it so that your patients, elderly patients, people that are there, I mean, we're talking about a university hospital, you know, can't get into the gift shop slash cafe that you put in for them? Or the medical library. The medical library had an elevator in it, which was great. When you got off the elevator was encased in a glass enclosure that just had pretty etchings on the glass, you know, with the name of the university. But I'm like, why? Like, why put in an elevator for people to utilize and then put it behind very large, heavy glass doors that have no buttons on them? For what it's worth, EVS used to struggle with them all the time as well, trying to get through them with their guards. Where I work now, and love my work. Every place has its thing. So when I come in the morning, I open up, there is a door. The door that I come in the very front, they did put a button on for me. Very grateful for that. I will give credit where credit is due. When I come through that, this is what I normally see. So you can see there's phlebotomy carts, and then down that hall, there's a fridge, and then over here, there's where we're putting some, you know, waste, and then there's usually an EVS cart, and it's literally, I'm weaving with my scooter because that's how I get in and out, so I don't have to walk really far and I can carry my stuff easily. Literally sometimes weaving in and out, many times there's things just like totally blocking, phlebotomists are all there. It's kind of like a little game at this point. I try not to even get frustrated about it. I'm just like, okay, I can't get through. And then I come down to the second part of this hallway, which is what you see on the right there. And again, you know, I always catch my crutches on those coats. I've definitely caught my drink a few times. I try not to, but it's tight, but I can get by. And then right around this corner that you can see I'm coming to on the far right back there, then I come to this. And I often come around this corner and there's literally a flat of stuff. Where the space that is left between the flat and the wall, sometimes I can get by, sometimes I can't. This one usually bothers me because my office is that fourth door down there on the hall, and I'm like, that's where I need to go to work, and now I can't get there. And you know, the buttons that are in the hallway are often blocked by things like this, and it's like, you know, yes, some people can lean and reach and get to that button. You know, me and my scooter, or even just on my crutches walking, like I can't necessarily finagle my way around stuff. Slowly down that hall, if I was to go out the back door, where the back door goes to the ER, it is a main transverse way, or way that a lot of people get to the ER. Again, there's a lot of stuff in the hall, and then you can see the filing cabinet actually comes out in front of the door. And they told me no, they would not put a button on that door for me, even though I asked. And that door is really heavy. I physically can't get through it. That may or may not be one of the doors I once broke a bone trying to open. And then here is the frozen room, and I love this one. So on the left, you can see there's a button there that says automatic, and right under the frozen room. That button does nothing. I have worked in this hospital for 6 years, and I did residency here a decade ago, once upon a time. That button has been here the whole time. I don't know what it goes to. I actually think it might have went to the button that, or to the door that's in the hallway. Right there, there's a fire door that I did not take a picture of. That's usually just propped open. I think it went to that, but I don't know. It doesn't go to anything. And you can see in the, and that door is extremely heavy. Again, they wouldn't let me put a button on it, and they won't let me prop it. So I usually just ask people to help me open it, especially after I had spine surgery to remove a tumor from my T4 vertebrae related to the broken fracture. I'm sure I'll talk about that a little more in person. But and then inside, you can see on the far right wall there again, there is a button. Maybe one time the button went to the frozen room door. I don't know. But like I said, that button is just there. It doesn't do anything. I also wanted to call attention. So this is our frozen room, and that's our frozen room scope. And you can see that desk is just mounted to the wall. And I wanted to get one that goes up and down. You know, I have a friend a colleague who's 6'4", and then I'm 5 foot, and I also have a short torso, and my spine's been fused in 2 different places. So, you know, doing frozens, you know, you need to be able to see in the scope. They did not want to take that desk out and buy a desk that went up and down. So instead they bought me that chair. So that chair in the middle is my chair. I use that, and it is typically just enough for me to use and see. However, clearly, if I was using my wheelchair, if I could not walk to get to that chair for whatever reason, then I would not be tall enough and I would not be able to do frozens. And as a matter of fact, when I came back from having my last spine fusion, I just told them, like, you can't put me on frozens right now because I physically can't do it. I can't see, and I can't be leaning like this, and I can't be, you know, sitting on books, et cetera, or moving myself out of my wheelchair into another seat. That's just not possible. So for a while I was like, I can't be on frozens. And then this is my favorite, our IHC room. Those are lockers. That lockers actually comes out in front of that door of like a full foot. That measurement there is 20 inches. And I'm just like, yeah, clearly with my wheelchair, I'm not getting in there. And it's even hard just to get into for our people in general. So I just wanted to kind of bring these things up because I know all of our labs often look like this. I know all of our labs usually need some updating and are often not thought of by the hospital as a whole. And sometimes there's nothing you can do about it. Sometimes, you know, you ask and they tell you no. What I find even more frustrating than that is when they're actively doing renovations, when they're already making a change or like putting in a brand new cafe and a brand new lobby, that they then don't think of that. So in general, what can you do? One, just be aware, kind of think about it. My friends who say they have kids in strollers certainly say they think about it more than, you know, before they had kids in strollers. Like, you know, if you're walking around New York, or if y'all want to hang out with me in New Orleans and see what that's like, you know, where there might not be a curb, or where there might be a curb, but it's got a huge pothole in it. And so then my scooter gets stuck and then somebody has to help push me out. Or places where there are just stairs to get in, or there might be an elevator, but the elevator is broken and they haven't bothered to fix it. Just kind of be aware of those things in your surroundings, and, you know, try to practice inclusive behavior. When I'm going to a committee meeting and it's a committee of only 10 people and they all know me, and then they're like, oh yeah, we're going to this restaurant in this private room that's only up a flight of stairs. And I'm like, you know, I'm not trying to have them not have an experience that they want to have, and I can appreciate that. But when you're talking about a city like Chicago or New Orleans or wherever, we always meet in big cities, when there's literally thousands of restaurants to choose from, you know, you don't have to choose the one that somebody can't get into. You can choose the one that easily is accessible, or choose a place that has a room that is not hard to get to. Or just call, and don't just say, do you have an elevator? Ask if the elevator is working, because we've had that a few times. Like I called and they have an elevator. I'm like, excellent. And then we get there and like, oh, it's been broken for 6 months. I'm like, oh, we didn't think to ask if you have a working elevator. And then try to fight for changes if you feel up for it. You know, if you, yeah, in a position where you can, particularly if they're already doing renovations, you know, it's easy to just ask people like, hey, you know, what might be the better way to do this? You know, instead of putting in these stairs, or if we're gonna have to put a door here, does it have to be, you know, a fire door? Does it have to not have a button. You know, how much does it cost to put a button on? They're anywhere between like 2,500 and 5,000. Grand scheme of money spent in hospitals, it's a pretty small amount. Just little things. I'm looking forward to chatting with all of y'all. Please feel free to reach out to me. Clearly, I have stories upon stories and can go on, but at this point, I believe I'm going to say my adieu. Here are some of the references for the things that I talked about, and there's many more. If you're interested, you can Google it or you can chat with me and I'll fill y'all in. And with that, thank you very much for listening. Never be afraid to come and ask me. I've been doing this my whole life. So I'm largely unable to be offended, at least not about questions from physicians, because we're curious folks. So feel free to come up to me and chat at any time or about anything, really. And with that, thank you very much, y'all.